Good evening, friends, and a warm welcome to episode 2 of season 3.0 of 4D. 4D is detailed discussion and dialogue in diabetes, in Indian diabetes. In 4D, we talk about the challenges that we face, and then we also talk about solutions that we have discovered, that we have improved upon, that we have improvised to help our patients, people who live with diabetes. Today, we have three experts from the Steel City of India, from Bhilai. And when you talk of steel, it's very important because the concept of resilience, the concept of resourcefulness, this is something that is second nature to all of us. Let's welcome our speakers for today and let's see how they'll help us add steel, that strength of steel, to our treatment, to the management protocols and practices that we follow. But you will find when we meet these three gentlemen, when we speak with them, their steel is tempered with softness. They are soft as silk as well. And that is what I find best about them. So a warm welcome to Dr. Rajat Dev, endocrinologist at Bhilai in Chhattisgarh. Dr. Rajat specializes in diabetes, in thyroid, obesity, polycystic ovary syndrome, and he's a very friendly, a very loved person in Indian endocrinology. Warm welcome, Dr. Rajat.
Thank you very much, sir, for the kind words. It's an honor to share the platform with you, sir. Thank you.
It's great having you with us. Dr. Rajat, when we talk about Chhattisgarh, all nice things come to our mind. Happiness, vibrancy, again, this concept of resilience and resourcefulness. Question is, what do you like best about your state?
The best part of our state is that then it is very close to nature. Almost 70% part of our state is almost covered with forest and the natural habitat. The indigenous people are there, especially if you look into the Bastar, the natural beauty is there. Apart from that, the rich mineral sources are there, which is almost one of the major sources of minerals and ores to the rest of the country. So that's the best part of our state.
And it's a state that everyone must visit at least once. And the thing is, if you visit once, you want to go again and again to Chhattisgarh. A warm welcome also to Dr. R.K. Sahu. Dr. R.K. Sahu is a consultant nephrologist and renal transplant physician, again at Bhilai. His interests include not only kidney transplant, but also glomerulonephritis, and also a new concept that we are speaking about these days, MACKD, metabolic associated chronic kidney disease. A warm welcome, Dr. Sahu.
Thank you, sir. Thank you.
Chhattisgarh is famous for its down-to-earth cuisine, very natural tastes, flavors. And I'm from Haryana. We call ourselves the rice bowl, the cereal bowl of the country. But we are very happy eating vegetables and fruits that are sourced from Chhattisgarh or Madhya Pradesh because we feel that their soil is better. There's less of pesticide, less of fertilizer. So we actually pay premium for the vegetables and fruits that come from Chhattisgarh. So Dr. Sahu, a question is, what is your favorite food from Chhattisgarhi cuisine?
ओके सर मेरा यहाँ पे मतलब दो चीज़ मुझे छत्तीसगढ़ में बहुत पसंद है. फर्स्ट ये कि एक्चुअली आई एम बॉर्न एंड बॉट अप फ्रॉम छत्तीसगढ़ ओनली. फर्स्ट यहाँ के लोग सर दे आर वेरी स्वीट एंड बहुत मतलब ये आप बोल सकते एकदम बोले बहुत ही अच्छे. तो आई थिंक वो एक मुझे सबसे अच्छा लगता है छत्तीसगढ़ में. एंड सेकेंड चीज़ यहाँ पे जो यहाँ का जो खाना है वो बेसिकली आपने बिल्कुल सही कहा, जो मैक्सिमम चीज़ें जो है ऑर्गेनिक ही रहती हैं, बहुत ही कम पेस्टिसाइड्स यूज़ किए जाते हैं. तो यहाँ सारे वेजिटेबल्स एज वेल एज सारे राइस इज़ very good in quality as well as organic. Yes, sir.
And that I guess happy company around you and good food, tasty food. That is what keeps us happy in life. And for the next 45 minutes or so, we will also be blessed because we're in the company of happy people, Dr. Rajat and Dr. Sahu. We have one more happy soul with us and he keeps our hearts happy. That's Dr. Gaurav Jain, a cardiologist again in Bhilai. Advanced expertise in pediatric as well as adult cardiology. His focus is on fetal echo, complex congenital procedures, and he has also branched out into metabolic cardiovascular disease. Warm welcome, Dr. Gaurav. There's a googly question for Dr. Gaurav. First, we asked Dr. Rajat what he likes best about Chhattisgarh. Then we asked Dr. Sahu what he likes best about Chhattisgarhi cuisine. Dr. Gaurav will answer the question towards the end of our meeting. And his question is, what's his favorite Chhattisgarhi beverage? A beverage that is found only in Chhattisgarh. What is special? And we'll talk about that later. But Dr. Rajat, coming to our topic for today. So people from across India with us. When we handle people with diabetes, when we handle people with other metabolic disease, it can be cardiac, it can be renal. Each person is individual. Does this mean that we write a different prescription for each patient? How is that possible? You have got thousands of patients, but all said and done, we have got only 5 or 10, at the most 10 classes of drugs. Do you actually create a different prescription for each person who comes to you?
Yes, sir. So individualization of therapy is the mainstay of modern medicine, because we need to take care of holistic. We need to take care the disease as a whole. So, if we talk about local people here, the staple food is rice, and most of the people here are taking 80% of their meal is composed of rice, steamed rice. So while we are giving much importance on protein intake, rice is a source of carbohydrate intake. So while we are prescribing drugs to these individuals, we must take care that we need to take care of the postprandial excursions which might occur in these individuals when they take carbohydrate rich diet. So definitely, even if we have 8 to 10 category of drugs, each have their peculiar feature, that some of them controls the postprandial excursion, some of them controls the fasting state, glycemic status. So that is how we usually individualize the therapy depending on their food habit, their cultural habit, their eating practices. And yes, with the present, we have a lot of options as compared to 3 decades back. So using these all category of drugs, yes, individualization of therapy is possible.
Thank you so much, Dr. Rajat. Dr. Sahu, Dr. Rajat just said that individualization of therapy or personalized therapy is essential, and it can be done. Is this true for people with chronic kidney disease as well? And then when you talk of this question, which maybe nobody has ever been able to answer, which comes first, the chicken or the egg? So 2 questions combined to you. Which comes first? Is it kidney disease or the rest of cardio-renal metabolic disease? Which comes first? And secondly, can we individualize therapy in patients with CKD?
Sir, exactly, sir. Kidney disease and I think cardiac is, I think, go simultaneously sometimes, and might be a cardiac patient. They have more chances of CKD, as well as similarly CKD patient, they have more chances of cardiovascular as well as cerebral vascular disease also, because pathophysiology of all 3 organs are important, or is the same, is the endothelial dysfunction. So I think they if any patient with a cardiac patient, they have a higher risk for similarly a renal patient have a higher risk for cardiovascular disease also. And second thing is, in our practice we see many patients have a different result with same medicine, as well as they have a higher chances of hyperkalemia and other like hyperphosphatemia seen with same diets results. Some patients have hyperkalemia and some patients have hyperphosphatemia also. So not only medicines, as well as nutrition point of view, all diets, I think individualization is required, because many persons show a different result with same diet as well as same medicines. So require this individualization of treatment is required, sir.
You mentioned individualization of treatment. Dr. Rajat, let's look at the presentation. Now, when you are in medical college, when you are trained in acute medicine, most of the time, whatever subject we are from, most of the time we see patients in a cross-sectional way. Patient comes to your OPD, you treat him today. Patient is admitted in your ward, you treat her for a week. And then the patient goes away, and when he or she comes back, they are seen by another junior resident, another senior resident. But in cardio-renal metabolic syndrome, is it usually a cross-sectional treatment that we are doing, or as consultants, is it longitudinal? So, and how has this insight or this thought process, how did it impact you in the early years of your practice? Longitudinal versus cross-sectional treatment.
So it's always good, just like studies, approach to patient is also, longitudinal approach is always better, because there is a possibility that when we first encounter the patient might not have developed every other complications, because when we talk about cardio cardiovascular, renal, metabolic complication. These are three different complications. Cardiovascular on one hand is a macrovascular complication of diabetes, whereas kidney is microvascular complication. So they might not happen at the same time. So here, longitudinal follow-up of the patient is much more important, because one individual may develop cardiac complication first, some individual may develop renal complication first. So that is why always a longitudinal approach is better. Yes, I agree that that is one of the limitation of our medical colleges, that some every year new students comes and different day different units OPDs are there, so one doctor might not see the same patient again and again. The same patient will see different doctors again and again, so that is one of the limiting factor. But longitudinal approach is always better than cross-sectional.
So, Dr. Sahu, continuing with this, when we use the word chronic kidney disease, we assume that it is chronic. But for people with acute kidney injury, do they need only acute care, or do they also need a chronic kind of a follow-up, a longitudinal follow-up? And can you generalize for everyone, or does everyone need a personalized approach there as well?
Yes, sir. Sometimes some chronic kidney disease may be because of AKI. And one of the cause for CKD, there is a risk factor of AKIs also. So any patient with have a AKI, especially if there is a glomerulonephritis, some post-streptococcal glomerulonephritis and some infection-related glomerulonephritis is the high risk of CKD in future also, because they have some immune dysregulation and leads to multiple AKI during any infection. So these types of specific patients may require longer follow-up, but some specific patient like diarrhea or multiple vomitings because of hypovolemia or any road traffic accident leads to AKI, generally they not required longer follow-up. But any glomerulonephritis, like some patient with young patient with nephrotic syndrome leads to AKI, they needs a longer follow-up, sir.
So suddenly what we are realizing, all of us who are logged in, and thank you Dr. Rajat and Dr. Sahu for your insights, what we are realizing is that we may be using just one word, type 2 diabetes. We may be just using one phrase, chronic kidney disease, but actually each and every individual is different. The etiology is different, the approach is different, and we have to factor our approach in separately. And this is all biomedical that our speakers are talking about. We have not even touched the psychosocial domain or the environmental domain. For example, Dr. Dev would have a different approach for someone from Bhilai city, and then he would have a different approach for someone coming from a remote district, someone who cannot come for follow-up for the next 6 months. Warm welcome, Dr. Jain. So, Dr. Jain, speaking about personalized care, now there is only one heart, isn't it? But if the heart was not there, forget the fact that the human body would not survive, we would not be able to live. But how would Bollywood survive if the heart was not there? So a question from the audience, and this question comes from Dr. Kanal Sharma. He's a cardiologist in Ahmedabad. He says, which is your favorite Bollywood song related to the heart?
Sir, I am very less intended towards all these, so nothing specific.
We understand that Mrs. Jain is also watching, so we move ahead. But now see, single heart, just one organ, and so many movies have been created on the heart. Each of them is different, and countless songs in Hindi, Urdu, in Chhattisgarh, in each and every language of India have been created on the heart, which means there is certainly a scope for personalizing heart health as well. So what does individualization mean to you? Does everybody with angina get the same treatment in your OPD? Does everybody with ASCVD get the same treatment?
No, sir. In today's point of time, the treatment and care has to be individualized. We have to risk stratify the patients. Not every angina patient is going to get same treatment. Stable angina has to be on medical therapy. Unstable angina is again classified as acute coronary syndrome. They have to be taken for coronary angiography. Same likewise, sir, ASCVD we have to risk stratify, and according to that we have to treat the patient whether medically or interventionally.
And we also realize that when we use these words, though these diagnostic labels, though we use them interchangeably, ASCVD would be a structural diagnosis, and angina, that depends upon the patient. The patient is
It's a
diagnosing.
clinical diagnosis. Yes.
Yeah, it's the clinical diagnosis. Patient is diagnosing. When we speak of personalized care, so we have seen that our approach is different for each patient, but until you measure, you cannot improve. So, Dr. Rajat, any advances in glucose metrics? Let's limit our answer just to measurement of glycemia. How are we able to measure glycemia better today as compared to maybe a decade or two earlier? And how does that help us in personalized care?
Sure. So today we have a tool that is continuous glucose monitoring, which is available nowadays. So the best part about that is it gives us a 14-day continuous. So it is not like a snapshot of fasting or PP or a 3-month average, which is HbA1c, which does not give us the information about the glycemic variability, which is readily available in continuous glucose monitoring system, the time in range and time below range, above range. So that helps us in individualizing that at which time patient needs medication for the excursions or the glycemic excursion that is happening at which moment of time, or to prevent hypoglycemia that might be nocturnal, which is not possible to measure by glucometer but possible with the help of CGM. So that is the advances that we have today.
Thanks a lot. And any other advances that we have? Let us say HbA1c is not possible. So is hemoglobinopathy common in your part of the country? And what are the other options that we have, supposing HbA1c is not accurate?
So we belong to a sickle cell belt that Chhattisgarh comes in that. So many patients have sickle hemoglobinopathy. So other than hemoglobin, we have we can use CGM for mean average average glucose. So apart from that, glycated albumin is one of the option that we can go for it, and fructosamine that is also available.
Thank you. And Dr. Sahu, continuing in the same vein, what about renal metrics? What are the tests that we do now to diagnose, to screen for, then to diagnose, and then to stratify CKD? Is a blood urea enough? That is what I was trained on. I was trained on blood urea and urine albumin.
Sir, as you already discussed, all the pathology is basically a endothelial dysfunction. The basic problem is endothelial dysfunction, and in case of renal point of view, before raising urea creatinine, patient have some form of proteinuria initially. So I think one of the best indicator for any diabetic kidney disease is the proteinuria. So any form of proteinuria, it's basically a CKD. If there is a duration of more than 3 months, there is a diabetic nephropathy. And second thing is urea creatinine is raised generally after starting protease, it's after long duration, maybe might be more than 5 years. So I think earliest detection is most important in case of diabetic kidney disease, because in initial stage till microalbuminuria we can reverse, but after raising urea creatinine it's difficult to reverse, and then there is only one way. There is a chances of progression only. We have a medicine, but generally after raising urea creatinine, most of the time patients generally not reversed. So I think most important indicator of diabetic kidney disease is proteinuria only, and other factors is important. There is any previous history, especially on a previous generation, if they have a diabetic and associated some renal disease, then very high chances of this generation they have developed diabetic kidney disease, then required more follow-up for these types of patients.
And Dr. Sahu, earlier would mean 3 decades ago, if we had to check for albuminuria, we had to do a 24-hour urine estimation. So that was standard of care. And many times you would admit the patient to make sure that the 24-hour collection is complete. Do we still have to do that in today's world, or do we have point of care devices?
Sir, we generally do a protein to creatinine ratio, because most of the time patient either over collected or under collected. So ultimately leads to there is some form of error. So we generally do a first morning sample with protein creatinine ratio. With most of the times labs are also not doing. So we have to collect in a morning sample first, and we should sample a very good labs. because in the local labs they have very random reports. They not able to even calculate that. So we generally ask to patient to come our center, and and they generally come and give their samples, and we look for protein to creatinine ratio only, sir. If specific patient we required some 24-hour urine protein, then we again, after collection of 24-hour urine, we ordered only 24-hour urine protein to creatinine ratio only, sir. Because we after this ratio we can basically the over collection and under collection we can avoid with this ratio, sir.
Thank you so much. And Dr. Gaurav, any advances now? Let us say I want to screen someone for acute coronary syndrome, or I want to screen for heart failure. Any point of care devices that we can use, and again, which are relevant to physicians across India, which make it simpler for us to do a triage. Should I send my patient to the cardiologist, or should I keep with me in internal medicine?
Yes, sir. There are some advancement in diagnosing and stratifying the cardiac patients. But sir, acute coronary syndrome is totally unarguable. If patient has acute coronary syndrome, he or she has to be taken for coronary angiography. But if the patient has stable angina, or he has some risk factors like diabetes, hypertension, or dyslipidemia, patient can be screened with a CT coronary angiography. It's a very good tool. Now, 128 slice CT scan can even scan plaque which are vulnerable to rupture, even if the stenosis is 30 or 40%. But if the plaque is vulnerable, it can suddenly rupture and cause an acute MI. So even that can be screened by 128 slice CT scan. That is a very good tool to screen. And if we ask about blood test, again, NT-proBNP is a very good test to screen for heart failure. Even to decide about the therapy, or even to prognosticate the patient, NT-proBNP is a good tool. We generally do NT-proBNP at the time of admission when the patient is admitted with heart failure, and at the time of discharge also. And even on follow-ups also, we regularly do NT-proBNP just to risk stratify. Few tests like lipoprotein A are also very good in diagnosing, stratifying the patient, even if the lipid profile or other tests are normal and lipoprotein A levels are elevated. Again, patient will be at risk of ischemic heart disease, and lipoprotein A level does not change after birth. It will be same from birth to death. So these are the few tests.
So, multiple things, but suddenly I feel like as if I'm amongst medical astrologers. We usually go to the astrologer to find out our present and our future, but here now we can use tests from endocrinology, from nephrology, from cardiology, from internal medicine, and we can actually predict what is going on in our lives right now, and then what is going to happen in future. Now, this is part of what astrology offers us in India, whether we believe it or not. But Dr. Rajat, one other very unique thing about Indian astrology is that apart from telling you your present and future, the astrologer usually will come and tell you an upay, or he will give you a solution. So we'll say you do such and such a thing so that you can change your destiny. Is that possible today in diabetes care? Do we have drugs like SGLT2 inhibitors, and can we say that these drugs can actually change our destiny? Can we defend our statement based on evidence?
Yes, sir. Definitely, in past 1 decade, we have tens of many studies that are landmark studies and proven that SGLT2 inhibitors are, and because of those studies, SGLT2 inhibitor has now become first line therapeutic option not only for diabetes but also for non-diabetic patients having renal as well as cardiac complication. So if we look into the cardiovascular outcome trials, we have seen that SGLT2 inhibitors reduces the major adverse cardiovascular events by almost 14%, and also the hospitalizations to heart failure reduces by 34 to 40% even in some studies. So yes, SGLT2 inhibitors are wonderful category of drugs which acts not only by control not only by glycemic control but also has renoprotective and cardioprotective action as well. So yes, it is possible.
Dr. Sahu, continuing with this, look at this statement. Dapagliflozin defines destiny. Is this correct from a renal perspective?
Yes,
And is
sir,
it correct
definitely.
from a, yeah, let's look at it from a positive way and also maybe a negative way. Not taking DAPA will define your destiny. So a renal opinion about this statement.
Right, sir. We already discussed by Dr. Rajat Dev, and various study like DAPA, CKD, and EMPA, both and trials shows the very good result with SGLT2 inhibitors. And we also seen in our OPD practice as well as over last 3 to 5 years, we have seen multiple patients. They have shown a good results, especially cardiac patient with some form of renal dysfunction. They have a good result, especially the requirement of admission is reduced significantly. Similarly, they have required less dose of diuretics, and there is less admission because of repeated heart failure or pulmonary edema related symptoms. And we also seen there is some negative things also seen. They have increased chances of urinary tract infection, pyelonephritis, fungal infection is there. But we also see there is a possibility of recurrent UTI in after starting a dapagliflozin or empagliflozin, because of one factor is the mechanism for that drugs. And second, we seen many patients who have a UTI. Generally, they are sugar are not well controlled. So another these two important things we should basically consider before starting or during our treatment with dapagliflozin. And we generally recommend the patient at least monthly or twice 2 monthly or 3 monthly follow up with urine routine microscopy, especially in an older age group with have some form of prostatic problem. And we generally look post-wide residual volume also. So this important thing we should see before starting dapagliflozin or empagliflozin, because the risk of UTI is significant. And as per Indian data, I think Indian as well as Western data, the risk of UTI is less. But I think the risk of UTI and pyelonephritis as well as fungal infection is significantly high compared to Western data, sir.
And Dr. Gaurav, let's talk about matters of the heart. Now, we spoke about astrology, and one of the commonest reasons for any individual to go to the astrologer would be maybe he or she is facing financial problems or there's an issue with matters of the heart. So, what does dapagliflozin do to the heart? Does it make it stronger or weaker? And can you confidently say that if you take this drug, your heart will become healthier, it will become happier, it will live longer?
Yes, definitely, sir. Since 1 decade, the cardiologists have been using SGLT2 inhibitors. Since there are many advances in the interventional cardiology, it has a negative part also, sir. Now, many patients we see with recurrent heart failure admissions. Now, it has been a part of our therapy. Dapagliflozin or SGLT2 inhibitors are now a class 1 indication for reduced as well as preserved ejection fraction, and it acts at a endothelial level, as sir told. It decreases even the albuminuria to a significant level also. If we have added all the drugs, all the therapy, still if the patient is having albuminuria, DAPA or empagliflozin we add and the albuminuria reduces. So and even the trials have proven that now they are definitely class 1 indication for heart failure, all the heart failure patients.
So if we share this information confidently with our patients also understand the kind of treatment that we are giving. Our topic for today is personalized care. So Dr. Rajat, let's talk about personalized care using dapagliflozin, and after that we come to sitagliptin. Whenever you use a drug, you should be aware of the indications, also the caution, like Dr. Sahu said, and then the contraindications. Let's talk about the contraindications of dapagliflozin from a glycemic perspective. Just pure glucose, the type of diabetes, the level of glycemia, would these have an impact on our choice of dapagliflozin?
Definitely, sir. So, if till now we have seen many studies that use of SGLT2 inhibitors, particularly dapagliflozin, in type 1 diabetes. So, since its action is independent of pancreas, there are many studies which have shown that using dapagliflozin has reduced significant amount of insulin requirement in those individuals. But yes, there always lies a fear of ketoacidosis, especially the euglycemic ketoacidosis in those individuals who are taking those, especially type 1 diabetes individuals who are taking dapagliflozin. So still it is not a
So we understood that in type 1 diabetes, we should not use dapagliflozin. Also in pancreatic diabetes. And if you happen to work in a part of the country where you see a lot of malnutrition related diabetes, there also dapagliflozin is contraindicated. DAPA is a CRM, calorie restriction mimetic. If your patient is already calorie restricted, is malnourished, has a GI dysfunction, which is preventing the patient from absorbing calories, absorbing carbs, DAPA won't help. Dr. Rajat, continuing with this, supposing our patient decides to go on a keto diet without telling us. So a keto diet or very low calorie diet on one hand and dapagliflozin on the other, what happens if both of them get combined? We'll continue the same question for Dr. Sahu. Dr. Sahu, in my OPD, we have something that we call nitrocathexis. This word again coined by Dr. Saurabh Sharma. So, Dr. Sahu, many times we have patients with chronic kidney disease. They
Right.
keep on taking treatment from us. Creatinine hovers maybe 2.4, 2.5, it's always the same. Suddenly, they come with a creatinine of 2.1 and they are the happiest person on earth. You ask them, what did you do? What did you do? So they said, I went to alternative therapy. They put me on a starvation diet. I stopped eating all proteins and see, I brought my creatinine down. What is actually going on in these patients, and should we be happy about that low creatinine or should we be sad?
Sir, yeah, I am actually this is difficult to explain to him because maximum time a patient have a muscle loss because of these types of diets, and actually the creatinine is because low because of these have actually they have a low muscle mass leads to low creatinine, but actually they have a problem is same as well as the other factors like they have a more oxidative stress and progression of kidney disease is ongoing. So I think this is a problem in our OPD also because some patient have a creatinine is low, but they are not able to walk or not able to do their daily activity also. So this is a difficult to explain him, but there is a problem. And after sometimes they have a sudden rise of creatinine as well as decrease in urine output and leads to early dialysis. Sometimes a patient, this type of patient have because they generally taking some medicine or something. They have they contain basically heavy metals and leads to acute kidney injury and requirement of early dialysis also, sir.
This is very common, and like Dr. Sahu said, it is difficult to explain. But then that is the beauty of personalized medicine. How do you explain? So some of the ways that I do this, I say that yes, this is a marker of nutrition as well as malnutrition. Now, if the serum creatinine is going down, that means you may be malnourished. We also can talk about Goldilocks zone. So Goldilocks was this beautiful girl who went into the forest and then she entered the house of the bears. So, one chair was too big, one was too small, and the other one was just right. So we say we want to keep your creatinine in the just right zone, neither too much nor too little. Another way of explaining would be if you're from agricultural belt, that when your rice is growing or when your wheat crop is going, you have to keep on adding fertilizer. You have to keep on giving water to the plant. Otherwise, the plant will not grow. If you're going to starve yourself, if you're not going to eat protein, if you're not going to take calories, then it's just like starving your crop. You're not going to grow. And the fact that your rice crop is growing or your wheat crop is growing, it means that it needs more water and more fertilizer. So we will keep on giving you that. Dr.
Thanks.
Gaurav, from a cardiac perspective and also from a renal perspective, one fertilizer that we have spoken about is dapagliflozin. So, dapagliflozin, does it have any contraindications in cardiology OPD, specifically from a cardiovascular perspective, not glycemic and not renal?
So as such, there is no direct contraindication of dapagliflozin from cardiac perspective, sir. But we generally see patients, asymptomatic patients, again coming with pustules in urine, and then some patients even ending up in pyelonephritis also, as sir told. and then we stopped dapagliflozin or empagliflozin. But as from the cardiac perspective, whenever patient presents with some endothelial dysfunction or prone to heart failure or even class A heart failure, who are at risk of heart failure but no structural heart disease, we start dapagliflozin, sir. But there is no specific cardiac contraindication.
Earlier, there was a contraindication: don't give an acute heart failure, acute kidney disease. But now there are so
Yes,
many
yes,
studies which
yes,
show
sir.
it there as well. The trick
Yes.
is that if your patient is taking adequate carbohydrate, and if your patient is taking adequate fluid, adequate water, then you can give dapagliflozin. On the other hand, if your patient is carbohydrate starved, is not taking carbohydrate, or is fluid starved, is not able to drink properly, is dehydrated, is hemodynamically unstable, then it may be a good idea to stop for a short period of time. Dr. Rajat is with us, and Dr. Rajat was speaking about euglycemic DKA. Now, there are only 3 causes for ketosis or ketoacidosis, only 3. First is deficiency of carbohydrate. If you don't take carbs, like in keto diet, you go into ketosis. Second is deficiency of fluids. You get dehydrated. And third is deficiency of insulin. If there's not enough insulin in the body, whether endogenous or exogenous, again you get in trouble, you can get into DKA. So, Rajat, let us say we have a patient who is on dapagliflozin and is doing very well. Suddenly, the patient goes on a starvation diet, a keto diet, a very low carb diet. Suddenly, the patient decides to keep a 24-hour or 36-hour nirjal fast without fluid. What can happen? How should we counsel such patients so that we don't get into, sort of untoward or unwanted situations? Many a times we say that 1 plus 1 is equal to 11, but that is not necessarily true in metabolic medicine. Dr. Rajat, so if your patient is on a keto diet earlier, then you know what's going on. But if the patient, without asking you, yeah, Dr. Rajat, please, without informing you, the patient changes his or her fluid intake or dietary pattern, then we can get in trouble, and we must be aware of this. It's a good idea to be in regular touch with your patient, even asking them each time, what do you eat, what do you drink, and that helps, continue. And Dr. Sahu, we've talked of dapagliflozin, but another drug that we use in practice is sitagliptin. So what is the role of sitagliptin in nephrology practice in a patient with diabetes and chronic kidney disease?
Yes, sitagliptin or other DPP-4 inhibitors are one of the good drugs in case of any patient develop a CKD, because there is a fluctuation of sugar is seen, especially in after developing a diabetic nephropathy or advanced stage of CKD. Then we required some other drugs from other than sulfonylurea, because there is higher chances of hypoglycemia with these types of long-acting sulfonylurea drugs. So sitagliptin, in which this is the very good drugs, in especially in any patient who have developed a CKD, when there is a very high fluctuation seen in sugar. So we generally start sitagliptin or linagliptin in especially any patient who have a early CKD. Then we start with sitagliptin, because sitagliptin has a better sugar control compared to linagliptin. But after stage 3 onwards, we generally switch to linagliptin, or may require dosing of the 50% reduction of dosing of the sitagliptin. And there is generally there is no other benefit of DP4 inhibitors on as a basically it's a neutral drugs, and there is a good things with linagliptin we can use in advanced CKD as well as dialysis patient. So there is very less chances of hypoglycemia as well, and there is no other side effect like weight gain. So I think after SGLT2 inhibitors and other drugs, if you required, then sitagliptin or linagliptin is the good choice, especially in a CKD patients.
We can use sitagliptin also in patients with advanced CKD. Just remember the numbers. If the eGFR is less than 60, you remember 50, then you give 50 milligram OD. And if the eGFR is less than 30, remember 25, give 25 milligram OD. So just remember that the dose per day will be linked with the eGFR. That's a rough way of remembering.
Right.
Many a times, like we face challenges, like technical challenges, supposing there's no electricity, supposing there's no bandwidth, even if the patient wants to come back, patient is not able to come back. So, Dr. Gaurav, does this happen in cardiac practice? And then how do you prioritize? Would you want to prioritize safety or accuracy? How do you handle patients with chronic cardiac disease, chronic cardio-renal metabolic disease, who are not able to come back to you regularly?
Yes, in India, we regularly see those type of patients who are not able to come for regular follow-up, and even they stop medications, and then certainly they end up in decompensated heart failure or something like that. I think better counseling just at the time of the regular OPD visit or the time of discharge. That do not, I specifically write that do not stop in front of those medication which has to be never stopped lifetime, like antiplatelets. I specifically mentioned that, and I specifically mentioned the date of follow-up. And even in some patients, we even call the patient that your date of follow-up is pending and you have to visit it on this date. But we see those type of patients like regularly on our OPD practice.
One challenge that we face across the country is that our patients complain we are giving them too many tablets to consume. This is true for people with diabetes, but the moment a person with diabetes gets CKD or CAD, cardiovascular or coronary artery disease, then the number of tablets jumps many-fold. So, Dr. Sahu, Dr. Rajat, how frequently you use fixed dose combinations? And do your patients complain to you that, Doctor Sahab, you are giving me too many tablets? I don't eat so many chapatis. I don't eat so many bowls of rice. But the number of tablets that I have to eat every day is more.
Okay, so first of all, using a fixed dose combination actually reduces the pill burden, and we have the luxury to use multiple drugs in a single pill. So, if we talk about the rational combination of SGLT2 inhibitor along with DPP4 and its advantages, we can counsel the patient that in a single pill you are getting more than one drug, and both of them are actually taking care of multiple pathogenetic pathways and will prevent the complication as well. So, yes, patients sometimes ask the question, but with counseling, they actually agrees to take this medicines, and this fixed dose combination are actually helpful.
And Dr. Sahu, do you face the same problem in nephrology practice? Patient complaining
Yes,
of pill burden.
yes, sir. Yes, sir. You have faced these types of problem because not only anti-diabetic drugs, the anti-hypertensive requirement in a CKD patients is very high. Generally, they have more than 2 drugs. I think more than 80% patient have required more than 2 to 3 drugs as an anti-hypertensive. And if any patient have a diabetic, then it's I think there is very difficult to explain the requirement of this drug is must and should be continued. So this is the big problem in our patient also, sir.
Dr. Gaurav, a message coming from someone, but she has purposely not written her name. She is from your undergraduate college. And she says that, Gaurav, a fixed dose combination is like a happy married life. Your opinion on this as a cardiologist?
Correct. Very true. Yes, sir. As a cardiologist, especially if the patient is having low ejection fraction, there are a list of drugs which has to be used, and ultimately patient tend to stop those drugs once they feel better. So again, fixed dose combination, we have a luxury. Different mechanisms will be taken care with one pill, whether it is multiple and like dual antiplatelet therapy, or whether SGLT2 or DPP. Nowadays we are getting dapagliflozin plus beta blocker combination also.
Yeah.
So those definitely reduces the pill burden, and patient are really means comparatively happy taking combination rather than single therapy.
And it helps improve bonding between us and the patient sticks to you. So it is like a lifelong kind of a relationship that we have with our patients, our community. And one very strong thing that I see from Chhattisgarh is a very strong person-oriented, patient-oriented, and community-oriented attitude or approach to practice that is coming across strongly from Chhattisgarh state, and which is very nice. We've been talking to each other for more than 45 minutes now, and we didn't even realize the time. That is what happens when you are with good friends. So, Dr. Rajat, a final question for you. What does personalized or person-centered medicine mean to you as an endocrinologist, as a diabetologist? And how can we use FDCs like maybe like Dapasita or other FDCs to enhance the feeling that the patient gets to us, that the patient gets when they come to us?
So every patient is different depending on its age, gender. So when we talk about age, so as per the ADA, the HbA1c goals are different for different age. So we cannot say that a 6.5 or 7 HbA1c should be a target of an 80-year-old male. We have to relax that. That is the individualization that we are talking about. That using a fixed dose combination and straight away starting two drugs should be used only when the HbA1c is more than 1.5% more than the goal for that individualized patient. Now that can be different. Someone can have a goal of 7% of HbA1c. Some person with comorbidities can have a 7.5, 8% as their glycemic target. So that is where the role of FDCs and combination drug comes. That if an individual whose goal is 7% comes to me with a HbA1c above 8.5, then I will straight away start two molecules, and using SGLT2 inhibitor and DPP4 will not only take care of the patient along with metformin, will not only take care of the glycemic part, but will also take care of the prevention of the micro and macrovascular complication of that patient. So that is what individualization means. That for every age group, the treatment should be different and the approach should be different.
Thank you. And Dr. Sahu, from a nephrology perspective, what does person-centered care, personalized care mean to you? Any examples from your OPD?
Sir, many patients in our OPDs are a different cause for they have a CKD with different cause. Like a diabetic patient, some diabetic patient have a less proteinuria, but they have some ischemic kidney disease. So generally, their patient have a good urine output, and there is as well as edema is less. Similar other patient who have a high proteinuria, and they have a chances of more chances of pulmonary edema as well as fluid overload. So I think every patient, especially not only in diabetic as well as other cause for this CKD if is different, then the personalized treatment as well as intake of especially fluid intake is most important, because in our patient is the main problem is the fluid intake. Patient have regularly complain of they have a dry mouth and require more fluid, but because of restriction they have some other problems like constipation and these types of things. So some patient have a good urine output, so we restrict less. If any patient have a decrease, they have a very less urine output compared to other, then we require more restriction of fluid. So not only fluid, similarly they have a different basically biochemical parameter also. So they have a require different personalized diet also. So I think every patient in our patient require personalized treatment, not only diet non-diet form is also a treatment form is also, sir.
Dr. Gaurav, we are talking about person-centered care, personalized centered care, and what it means to us in our OPD. You can give your heart to only one person at one time, and that is true for most of us. How does the cardiologist take care of so many people and their hearts at the same time? The question is, how does the cardiologist do that?
Definitely, sir. Personalized care is of utmost important in today's point of time. We have to assess the patient through all the modalities and then decide about the therapy, whether the patient is in fluid overload or patient is well managed. We have to decide about the dose also as per the modalities like NT-proBNP and echo, again being very useful in deciding whether patient is overloaded, seeing the IVC or the pulmonary artery pressure, seeing the ejection fraction or a diastolic dysfunction again is very important, and then decide the therapy. Start like all the modalities, all the pillars of therapy as far as possible. Seeing the blood pressure also is very important. If the patient is having low blood pressure, again we cannot start all the pillars of the treatment, and we have to start second line of treatment. And if the patient is having a good blood pressure with good creatinine level, again we tend to start all four pillars or 5 pillars of heart failure therapy. in not only heart failure therapy, other drugs like diuretics or antiplatelets again has to be decided as per the patient situation. So again, personalized care is of utmost important.
Right. So thank you. And there's a strong message that we are getting from all our experts today, from Dr. Rajat Dev in endocrinology, Dr. Sahu in nephrology, and Dr. Gaurav in cardiology. When the patient is in front of you, talk to the patient, look at the patient, listen to the patient, get whatever tests are required. Then you practice what is called participative prescription writing. Make the patient a part and parcel of the prescription writing. Find out what their needs are, what their requirements are. Finally, we don't have too many drugs. All said and done, the total number of drugs that are available or the number of classes, we limit ourselves to just 4 or 5 pillars in cardiology, nephrology, and in diabetes. So it's not more than 5 pillars that we have in each specialty. For the physician, a total of 9 or 10. But how you choose them, how you prescribe them, and how you follow up, that is personalized. That varies from person to person. And once you're able to master that art, and the way our experts have done for us, you master the art with a smile. So thank you, Dr. Rajat, for your smile. And thank you, Dr. Sahu, for smiling and being good to your patients. And especially Dr. Gaurav, thank you for bearing with us and for talking to us about matters of the heart. Once you're able to achieve that, then your journey with the patient, your journey in diabetes, in cardio-renal metabolic syndrome, that becomes very smooth, it becomes very satisfying. And that is what makes us happy. That's what makes us going as physicians. On this note, I'd like to thank our experts once again. Thank you, Dr. Rajat.
Thank you, sir.
Dr.
Thank you, sir.
Oh, thank you, and thank you, Dr. Gaurav. And thanks to each and every one of us who is logged in today. This is 4D Season 3.0, detailed discussion and dialogue in Indian diabetes. And stay tuned for further episodes throughout the coming year. Thank you and
Sure. Good night, sir.